Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
I'm really, really great. I have this fancy mic, as our guest just pointed out, trying to keep up and up on the audio quality.
Well, there's no doubt you're impressing the masses, and we do want to introduce our guests. But because we are not just a podcast, we are also a YouTube podcast. They can see the audio visual, so that's important that you impress.
I remember early on in the pandemic when we were doing all these webinars and whatnot, I got this really cool gold microphone. It's a Yeti. That attracted a lot of comments. It made me look like a mid '90s rapper, is what I was told. So I was happy with that.
So I guess I'm
Can
not.
I share? I should share a picture of you in your rapper outfit from Aleem's birthday.
Yes, yes, yes. That is something that might surface on the interwebs at some point. I was told
Yes,
the residents were happy that I gave them easy fodder for the roast. I'm sure it will show up pretty
yes.
soon.
I'll have to share that with Chuck here if I have a
I,
picture.
I think I've seen it, and I quickly tried to forget it. Um,
Yeah,
so the voice you hear is Ryan Nunley. Ryan is a reconstructive surgeon focused on the knee, and he's one of our partners here at Washington University. His accomplishments are many, and I mean that sincerely. I'm not prepared to do a like a visiting professor introduction. Ryan did his residency here. Did you do your fellowship here too? Yeah,
I did. I did.
did
Yep.
his fellowship
Clearly,
here.
clearly not the visiting professor introduction.
Yeah, well, anyways, and then he's been in practice with us. How many years is it now?
Since 2008, so I guess 15.
Wow. And Chris, when did you join? Like 2015?
Exactly. Thank you. I'm glad you know that.
That was a
Well,
total
let's be
guess.
let's be clear. Ryan's the man. He is an amazing arthroplasty surgeon. He is our go-to person. At least I probably should not say this on the air, but he is my go-to person when I send people for arthroplasty consideration. Although we have fantastic partners. And Chuck, he's your surgeon.
Yes, well, he is my surgeon, and I think we talked about this a little bit on the air. I am the time of recording, I'm 2.5 weeks out from a computer navigated uni knee replacement, which is going incredibly well, and we're going to sort of use that perhaps as a launch point for discussion. And we thought, Ryan, this is sort of part of a new perspective we're bringing, asking partners from different subspecialties to bring information which we believe will be helpful to the listeners. So we had Marshall Burks on, which was maybe more focused. We talked about clavicle fractures, but I think Ryan's expertise in seeing the tech advancements in arthroplasty will really serve the audience well.
Absolutely. And just so you know, Ryan, Marshall actually got a couple of emails based on his appearance on the upper hand. So perhaps your
Uh-oh.
expertise will be growing even more and your reputation will be expanding. Before we jump into formally having Ryan on, I think we should thank our practice link sponsor.
Perfect. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
So, Ryan, Chris and I talk a lot about efficiency and being busy. In our humble little world and in our humble little mind, we think we're both pretty busy and pretty efficient. But I have to say, I hold you out as someone who I absolutely know is busier and has to be therefore more efficient than Chris, maybe not me. Um, so tell us a
Fair.
little bit,
Absolutely fair.
tell us a little bit about your practice, if you will.
Yeah. So first, one thing just to correct you, so the audience knows, yours was computer. It wasn't computer navigation, but yours was robotic. So we'll get to that maybe in the technology part, where it's gone from navigation to robotics. But in terms of efficiency, the hard fact is that if we look at the baby boomer population as they mature, there are more and more patients this year than ever that have turned over 65. And naturally, as they get older, they require more orthopedic procedures, specifically hip and knee replacement being some of the most specific needs that they have. So with that, you have to figure out, how do I see the patients? My wait list to get in for a new patient is 6 to 8 months. I get constantly barraged emails, calls to get family members, friends in. So either I could turn the doors, shut the doors and say, I'm only going to see X number of patients, or learn how to be more efficient. I think many of us are feeling that push, especially as we've really not expanded the size of med school admission and or orthopedic residencies. So we're same number of physician providers, but growing patient demand. So some of that is using technology. Some of it is also figuring out ways that you can be more efficient, both in the operating room with the same team. I think it's probably a little easier in my world, where I'm doing, one room is going to do 6 primary hips and the other room 6 primary knees. And so the change over the room, the time between, every team member knows exactly what their skill set and their job is, that we can become more efficient from that perspective. A couple things that my practice after the pandemic really helped was the use of telemedicine. Some people love it, some people hate it. Again, maybe a little easier in the hip and knee world than the hand world, where the physical exam is not as important. Sometimes you can see from an x-ray, patient has a terribly arthritic hip, or they have a failed implant, and doing the telemedicine. So to my efficiency, every morning I start with telemedicine at 6:20, and I see 5 patients before my clinic starts at 7:30, or before my OR starts. So 4 days a week I'm doing that. That adds 20 more patients on, and it adds a very little stress to my team, because they don't have to check the patients in. They don't have to get there earlier. Patients absolutely love it, because they can sit at home and have a cup of coffee. If I'm running a few minutes late, it's not like they're driving 2 hours here to wait 2 hours in my waiting room. So I've used that to my advantage, especially with our physician extenders, nurse practitioners, and physician assistants who may have worked up the patients, or other partners, our sports partners who have gotten x-rays. Says Miss Jones has bone on bone arthritis of their knee, doesn't need a sports procedure, but needs to see Dr. Nunley. Since they've already performed an exam and have an x-ray in the system, I can review that and quickly have the patient on my schedule for surgery if that's the road we're going to go. So that's sort of the efficiency in the clinical side. I'll sort of
Well,
stop there.
first off, I'm humbled by
Yeah.
that. So that's pretty incredible. Kudos to you for utilizing telemedicine in that way. There's so much that you said that I want to dive into. The first thing I want to ask is, how do you handle the, emails from partners and from, acquaintances and other, people at the medical school saying, hey, Ryan, can you get this patient in, or I need to see you, or a family friend needs to see you. How do you handle that?
Yeah, I can add a layer of stress. I mean, I think one thing is that these patients typically are already at a point where they need something surgical. It's not just they're coming in because they have a little knee pain. 2, I do think that it helps with outreach to the community. So other providers who can email you and quickly get it in. And then 3 is probably just being organized. If you get a text message, an email, a my chart, it's coming in from all these different angles, having a point person. So one of my nurses, she always calls it the VIP service. She's like, every week I get 20 VIPs, and they're not necessarily that these are VIPs, but these are people who have directly contacted me. And so I think from that perspective, 1, it's being efficient to respond back to those individuals who are reaching out to you. For example, a nurse in the OR gives me a sticker with their mom's name. Can you get my mom in? I just quickly take a picture of it and I text it or email it to my team. Otherwise, I forget about it. So you can get lost in that. So having a protocol in place that makes it efficient for you as well as for your team is important.
That's really well said. And I'm sure Chris gets some of those. I definitely don't get 20 a week. But I think your point of having a system and responding, or just checking it off your list ASAP, is vital. I'm really good with staying up with email. Texting, if someone texts me, I try to text right back, because if I don't, it just goes down the line and I lose it. And you're right, you're getting it from all sides, verbally, epic, text and email. It's your system sounds really good.
It's funny how you said that you're good at email. I'm the opposite. The text messages, I don't have all the spam, right? I come out of the OR and I'll have 200 new emails. And so I'll try and delete. And there may be an important one. I get to it, but then I come out of the OR, there's more. And so then all of a sudden I feel the opposite. The text to me is much better, but I guess maybe it's different amount of inbox messages.
Yeah, for sure, for sure. So, talk to us a little bit more about your use of APPs or physician extenders. Do you use them in the clinic? Who helps you in the OR besides residents and fellows? How do you balance, if you do, I'm not even sure you do, trainees, if that's the right term in 2024, and
Learners, Chuck, learners.
learners, thank you.
Learners.
How do you balance learners and staff?
Sure. So I think the first thing is, when you look at a practice, while you may be the captain of the ship, every member of the team touches and influences and has contact points with your patients. So it's like any great relationship. If you have a good relationship and you trust and you're able to utilize them, then it's meaningful. I'd say there's a great book called Traction by Gino Wickman, and it talks a lot about putting the right person in the right seat. So you could have a great assistant, but maybe doesn't interface with patients very well. It's better in the back office. So you may have somebody who's really, great at doing the hands-on stuff, but it's terrible at the computer work. And so getting that right person. And I think the same goes for the advanced practicing partners. We have great ones that can really do a nice job injecting. Routinely, and you guys may appreciate this, if you're not doing all your own injections, but you have somebody else, when your nurse practitioner did it, it hurt, it was miserable, I only want you to do it. Well, that's not really helping you. So getting a partner in that sense that does it the same way you do, trust you, is responsible. And they can be great because they really do interface with the patients quite a bit for the non-urgent stuff. So I see all my own patients, but for annual follow-ups of x-rays, 1 year, 5 year, 10 year, if they're doing well, usually we'll send them to our physician assistants, or for routine injections that come in every 3 months. So it's a great resource to have as long as you trust the person and they do a nice job. I think that helps. In terms of the learners, our residents and fellows, my clinic is busy. I typically see outside of telemedicine about 55 to 60 patients in clinic. And part of it is they also have to learn how to be efficient. The orthopedic exam for hip and knee is a little different than hand. It's a little different than medicine. And they have to be able to quickly go in and say, is this a patient who needs services, or is this a person who needs their hand held after surgery? Is this a person who has a complex problem? So you don't need to spend 15 minutes with each one. Some need a minute, some need 10 minutes, some need 30 minutes, and to get through that in an efficient way and having them make decisions. So I really make them go in and see the patient, come up with a full plan, and leave me the notes and let me sort of go in independently and see if we come up to the same conclusion. Then we sit around and talk about ones where there's discrepancy. In the OR, same thing. It's a graduated autonomy. They have to at some point have the reins turned over to them. So making sure that they are comfortable with every step and knowing we can outline these steps in advance, because a lot of what we do is repetitive, that they should know it should take you 3 minutes to get to this part of the case, and this part should only take you 5 minutes. And I do encourage them at the beginning of the rotation. If you think about how you can save 1 minute on every single case over the course of 6 weeks, you should be 30 minutes faster by the end once you've done it. So emphasizing those points, teaching the finer details of how they don't have to do every step of the case. For example, putting every one of the retractors in and then turning around to do the next step. We have 2 other assistants there, myself and usually a first assist from the OR, that should each be doing our own work so that it's very fluid and efficient.
My God, you're speaking Chuck's love language right now in terms of efficiency. This is the sixth love language that isn't often described. So I think your point's really good about all of them, but particularly the coming the learner and the examination and coming out of a room. Oftentimes when I start working with a new learner, I give them the Goldfarb speech about how you have to come out of the room with a plan. Even if your plan is wrong, you need to have a plan. And I remember hearing that, being on the receiving end of that with Chuck. I think Chuck probably wants to unpack a little bit of what you talked about. We probably should talk about some of the technology stuff since we're pretty far in right now. But before we do that, we should thank our sponsor, Checkpoint, which is Checkpoint Surgical is hosting a webinar in April on selective and hyperselective neurectomy. That sounds fancy.
Sorry, I screwed up. Ignore me. Will you start that over with the sponsor message?
Before we get into the technology aspect, which I know we should thank our sponsor, Checkpoint Surgical. They're hosting a webinar in April on selective and hyperselective neurectomy. I don't even know what that means, and its role in managing extremity spasticity. Dr. Scott Cozen, one of Chuck's bros, will facilitate the webinar, and Dr. Kitty Wu from Mayo Clinic, who has a friend of WashU, will share how her program is expanding the utilization of this strategy to the lower extremities.
To learn more about this course and other upcoming educational programs supported by Checkpoint Surgical, including our own here at Washington University, please visit nervemaster.com. Hyperselective neurectomy, that immediately makes me nauseous. So I don't want to learn more about that.
Oh, come
I
on. It's
don't. I
really
want to
cool. I
know
mean, I saw
who's the Nerve Master. I want to
that
say Nerve
Nerve
Master. There's
Master.
only one of them.
I'm amazed that Checkpoint got to that URL before I did. That should have been mine. Damn it. No, so we have our peripheral nerve course. Actually, the plastic folks asked us to call it the WashU nerve course, not the peripheral nerve course, because apparently there's no difference now. But we have our WashU nerve course coming up about 3 weeks from when this episode drops. Spots are filling up fast. There's actually only a few more spots. So by the time this airs, there may not be any more spots. You can get on the waiting list if people don't show up.
Ryan, there's space for you. You know, there's always room to expand.
Well, there is the uncomfortable post-operative nerve foot drop that occurs occasionally. That's always a very gut-wrenching moment when the nerve doesn't function on the first post-op check or in the morning. So I may have to attend and see what there is new out there.
Well, let me know how it goes.
I don't think you'll have to attend, right? But all right, so you drew a distinction between computer navigated versus robotic knee replacement. And knowing that most of our listeners are orthopedic or plastic surgeons in training, hand surgeons training, or hand therapists, can you just kind of give some broad strokes about what does it mean to have a robotic assisted knee replacement, and what does it mean to have computer navigation used in arthroplasty or joint replacement?
Yeah, so I mean, the goal of either of those is really to make the surgery more accurate. When we look at how you do some of your surgeries, if you're going to do an osteotomy, you sort of preoperatively plan, you're going to cut this. And so the old adage of you measure twice, cut once type of principle. Well, that's a lot of what we're doing every day with a hip or knee replacement. So probably at this point now, almost 20 years ago, navigation was a utilization of technology to put pins at a fixed point into the bone with arrays that a sensor could pick up that can tell motion and angles, and then allowed surgeons to try to reproduce the cuts more accurately. And it seemed to fade out over time. It was very, for lack of a scientific word, futzy. There's sort of difficulties with the data in and the data out. And then sort of fast forward to probably about 12 years ago, the robotic side. So as you saw in the general surgery world with the Da Vinci, the utilization of robotics. And for probably the first 5 to 7 years, there was slow uptake. But with that, a lot of the major orthopedic companies have put a ton of time and resource into updating the robotics, making it simpler, faster, more reproducible. And with that, now the growing trend in total joints, especially in the knee world, is that the large majority, if not by the time we get to the end of the decade here, probably all of them will be done in some form of a robotic assistance, just because it takes the human factor out of it, the AI, the capture speed of the cameras. So when we say robotics, it doesn't mean that you push a button and you sit back and have a cup of coffee, like our anesthesia providers, and read the paper. It's more that you actually have to take and design the knee in three dimensions, figure out where you want the implant to go, and then the robotic arm holds the saw so you don't have to mount blocks onto the bone to make the cuts. And so it keeps the accuracy by just allowing you to pre-plan that on the screen in 3 dimensions with the CAD models, and then to simulate what the soft tissue tensions would look like. And again, the advent of that has really made it much more of a reproducible surgery. And then it allows us to sort of question some of the original premise of what our alignment targets were, now that we have robotics where we can more accurately do it. So you're seeing a huge change in the discussion of not just the traditional type of implants, but now really the alignment and the goals that we should to restore the kinematics to the knee.
So, okay, obviously I didn't have a clue because I screwed it up when I said what you did. But and my wife loves to like, it's so interesting. I'm so like precise and anal retentive about my life, but for this surgery and other things like surgeries, I just sort of say, okay, I know Dr. Nunley's going to take care of my surgery. I'm not delving into the details. And she got really frustrated with me that I didn't know what was going to happen when and where and why. And I guess it's just a form of neglect. I don't know, but thankfully I put my knee in good hands. I had X-rays 9 months ago, and then I don't know, 3, 4 weeks before my surgery, a CT scan. And so, what part are you adding work before the surgery, or is all of this done literally intraoperatively with the robot, with the CT scan? And what's the preparation, and how long does that add? Does it add to the surgery? Just help us understand that process.
Sure. So great question. The X-ray, as you know, is a two-dimensional image. So it gives us sort of a screening and evaluation to know that you have arthritis, what your sort of basic alignment looks like. The CT image takes selective images of your hip, very detailed of the knee, and then selected images of your ankle, which can give us alignment and rotation. From that point, that's all uploaded into the system and onto the robotic computer in advance of your surgery, done by actually the company representative. So no extra time effort there other than ordering the CT and making sure for my staff that that it gets uploaded. Inside surgery, we use a special instrument to touch various points within the bone to map it so that the CT scans up on the screen. Now you have to map it to where it is in space, the actual knee. So using a guide to tap several different points on the knee, it validates that you've now lined it up. And with that, then you can take the knee through functional range of motion, stress it to see what the soft tissue tension looks like. And from that, you have a full screen. Within a couple minutes, you adjust here, the angles, the slope. And so you get a graph showing you when you've sort of hit the target that you're trying to achieve. So that workflow adds, for somebody who's very efficient, maybe 2 to 5 minutes of time in the OR. But it saves you on the back end because now you're not having to mount the blocks onto the patient and make cuts and then take the screws out and remove the blocks. So as soon as you approve the plan, you go to the robotic arm and it just holds your hand in those positions that you've set to achieve the goals. And then you put your trials in. So after the first couple cases, the learning curve short, probably doesn't add a whole lot of time onto the case, maybe less than a couple minutes. The negative, as we're a little bit outside of the technology world, is the cost associated with things, right? We're all very sensitive to cost and new technologies. Just to put it in perspective, the robotic arm runs the hospital about $1.4 to $1.6 million if you get all the bells and whistles for the capital charge. Then there's a service contract of your company representative, your product specialist, that's between 100 to 200,000. And then there's the disposables. It's a different type of saw blade. It's a different type of arrays that go on your probes and things that are disposable. That can run anywhere from $500 to $900. So there is a cost born into the healthcare system, which the CEO and the CFO don't really like. But there is efficiency or there's improvement by potentially reducing readmissions, reoperation. And for you, Chuck, obviously you want one surgery, you want it done well once. You don't want the thought that, gosh, if I was off by 2 or 3 degrees, you have recurrent swelling and pain, and you may not achieve the best goal possible. So I think that's what it has helped, is reduce the outliers. So we have lower reoperation, higher patient satisfaction scores, and that's a win to our community.
And you are very good at patient satisfaction scores from what I recall. So kudos to you.
except my wait time to get in clinic. For some reason, get hammered on that.
So in classic Chuck fashion, I want to ask you, say 2 things. So, I guess the first one is, you've touched on cost. In our last episode, Chuck was talking a little bit about some of the challenges with, the insurer approving navigation, which clearly he was wrong because he wasn't actually getting navigation. So maybe that's why they didn't approve it. But what are the challenges on your end in terms of getting that approved? Is there additional work or a different CPT that's associated with navigation or robotics or technology in general for arthroplasty? And the second thing I wanted to ask you is, I remember when, everybody turned to doing, for example, lap appy, so a laparoscopic appendectomy, and very few people were learning how to do an open appy. What do you think this does for our learners who are coming up in the age of technology? Could they do a primary hip, a primary knee without the bells and whistles of navigation and technology?
Chris, you're asking great questions. So the first one about the insurance and approvals, like anything, different insurance companies have different approval process. But yes, there is some pushback from the private insurers with regards to getting a CT scan approved, even though it's a pretty low cost imaging, since it's not really if you really do it the right way, you own your own surgery center or imaging center, you could probably do it without the professional fee, since it's just looking for alignment. But you still get feedback, and that does sometimes generate some peer-to-peer calls. And most of the time, there is an additional code for the surgeon for using navigation or robotics. Rarely is that paid for, so we just sort of write it off because we think it's what's right for the patient. In terms of your question about, yes, going to advanced technology and utilization inside the surgical decision making, what happens when robotics or navigation goes down? And it does happen. We had a case the other day, a 85-year-old patient where the pins going into the femur, the bone was so soft, halfway through the case, the pins had loosened enough where once the system recognizes that you're out of the optimal range or that it's not mapping correctly, your whole cut plan goes away. So you do have to have a bailout. It's interesting as we interview our potential fellows for our fellowship, that many of them coming out of training who have only had robotics really want to go to a program that teaches them not just robotics, but also conventional, because of the situation I just explained. Or they may go to a job at a hospital that promises to buy them a robot, but may not have it for the first year or two. So I do think that there is an art form to knowing not only the technology and how it makes things better, but when it doesn't go well or fails you in the middle of something, you have to be able to bail out. So that is a challenge that as we get more dependent on the technology, I think we still have to remember the basics.
Yeah, all really interesting. It's I think I was talking to Chris, I think it was on the podcast. I always get confused about what we talk about and what's on the pod, but I was really frustrated when I heard that the insurer was not going to pay for the robot for my surgery. And so I called the insurance company. Like it just hit me the wrong way, like because I just felt like it was wrong. And it was the classic, well, it's experimental. And then I started doing the literature review, maybe on the wrong topic. I may have been looking at computer navigation. But anyways, I talked to your staff and they're like, yeah, it happens. Don't worry about it. But yeah, just super interesting how, and I get it from an insurer standpoint, and I get it that the cost from a hospital system standpoint, it's a real consideration. And some people certainly talk about both computer navigation and robotics as a marketing tool. I personally, and I'm sure you agree, and may have far more intelligent things to say about it. It feels really important for the future because, as I understand it, my medial compartment was the worst you've ever seen. The arthritis was horrible, and you probably had to have a robot help, and it was so bad.
Well, I would say yours was bad. I've certainly seen worse, but no, yours was bad. And you really limped around for quite some time. And I think you were tired of your wife complaining that you couldn't keep up with her. So yeah, it was the right decision. But to your point, I think when you look at technology, one of the advantages of forward looking or even knowing from the past is that the costs will start to come down, right? New technology, ceramic heads were an upcharge of $500. Well, then they realized if everybody's using it, the contract, they just renegotiate it down. Same thing with cementless technologies. But the companies, to your point about marketing, the companies certainly recognize that selling robotic arms and the disposables helps their bottom line. So they push it and they definitely market it. And there are certain areas of the country, whether it's robotic total joints or if it's, who knows, some other specialized hand procedure, endoscopic carpal tunnels. There is always a natural tendency for some physicians to use it as a marketing tool. And there's billboards that'll, you'll see our commercials on TV. We at Washington University, we have no billboards. We have no fancy marketing. I think at the end of the day, sure, these technologies can help you, but if you're still not a surgeon who takes the time to make sure all the other components are optimized, the patients have good outcomes, you still have other issues with readmissions. The robot does not solve all your problems. It's just another tool like anything else, and you have to use it that way. So I'm not really big on using it as a marketing, but more using it for what I think is best outcome for our patients.
Yeah, I mean, the direct-to-consumer advertising, especially in the arthroplasty world, is pretty real. People see it all the time, and I think it generates a lot of questions. I mean, the closest thing we have in hand surgery world is, like you're saying, endoscopic or some of the ultrasound-guided carpal tunnel stuff, but then also the collagenase gets pretty advertised pretty heavily. There's a John Elway commercial for the collagenase that often gets referenced when patients come in. And it's good because it does raise awareness, just in general. As we bring things to a close, I wanted to ask you one question. I mean, so obviously it's out there that you operated on Chuck. I mean, how do you handle operating on, people that you know pretty well, either partners or spouses or friends or family of partners? Do you do anything differently? Do you approach that differently? Is it a sensitive thing? Would you operate on a family member, for example?
And maybe I'll jump in before. I actually talked about this, not with Ryan, because I'm curious to hear Ryan's response and who did my surgery. But I specifically would never say I want, as a surgeon, I would never say to you that I want you to do my surgery. I want things to go exactly like they always go, and I think the three of us probably agree. I don't know Ryan's philosophy, but it's a super interesting question, and like there are some surgeons that hesitate to operate on partners because I guess concern of outcomes and stuff. So yeah, it's a great question. I really look forward to the answer.
Yeah, so I think you're right. I've probably operated on, I don't know, maybe 20 of the nurses or their spouses or their family members in the OR. So you see them daily. And I think one, you have to recognize what your skill set is, right? If it's something that you don't routinely perform, and somebody says, I love Dr. Nunley, I want him to do hip resurfacing, and I haven't done that in a long time, I would say, I'm not probably the right person for you. And you have to be able to be willing to acknowledge that we're not God's gift to surgery. And there's some things that we do well, and some that probably somebody else can do well. Second is, making sure that everything goes well, because you will see these patients, but it's the same as you would for anybody else. I mean, I run into people in the grocery store or, at the airport that I've operated on. So I try to treat every person as if they're a family member, take the time, answer the questions, and to the efficiency standpoint of it. If everybody has a job, then everybody has a job. So for Chuck's surgery, I did the whole thing, but I also close all of my wounds because I'm that super anal about that. I think that to me is the reason I have such a super low infection rate. It's not because I'm such a great surgeon, but for me, I've spent a lifetime and a lot of my research and teaching on wound management, because every orthopedic surgery has a wound that needs to be closed and sealed, and a little drainage is actually a disaster. So I do try and do things exactly the same way every time, because there's a reason we came up with those protocols. There's a reason that I felt like this works well. And then when you start to deviate, that's where you, I think, can run into problems. So from that perspective, I think it's one, treat everybody like they're a family member and that you'd want the best for them. I would not probably operate on my wife. She's totally non-compliant. One of our partners operated on her and said no weight bearing, and I pulled up our Ring camera 2 days after surgery. She's walking through the house with her crutches, and I called her out on it. So I would not operate on my wife, but I would operate on either of your wives, because I know they're much more compliant.
I have one easy and one maybe harder question, and then we can bring it to a close. Obviously, unless you have other things you'd like to mention. I should say, though, not only is Ryan efficient, not only is his practice volume incredible, you have been prolific in the research world, and I mean, you really balance a lot of things, which will be getting to my second question. My first question is to the wound management. I don't even know what it's called. What's the mesh stuff on the skin? It's awesome. Like if you had told me you got to spend an extra $50 to put this mesh stuff on, and I would have to pay, if you said do it, I would do it. But it seems like cost to the system, but it really is incredible, and it gives me confidence that my wound is not going to break down. So hey, that's my first question. And then the second question is, I'll use the 2024 lingo. Talk to me about work-life integration, not balance, integration.
So the first question is, yes, part of my philosophy about wounds is that I hated staples, and drainage was the albatross for the total joint surgeon in the infection, because now you're washing it out after a long clinic or long OR day. So doing research, and that's a full hour dissertation. I'm glad to talk to you offline. But the mesh that you're referring to it's a using product name. It's by Ethicon. It's Prineo. And so it's using the typical Dermabond glue, but the glue over a linear incision like the knee, when you start to bend it with therapy, puts a lot of strain on it. So that little bead of glue wasn't substantial enough. So the mesh is about 1.5 inches wide. So it dissipates that tension across there. And the beauty of it is that, one, you can take a shower right away. Everybody feels more human if they can take a shower after surgery. Two, going along the philosophy of decolonizing the body. Now you've been in the hospital, especially if you stayed overnight, you potential for nosocomial type of contamination and colonization. You can get rid of bacteria when you shower. And three, it allows you to just leave it on and take it off with no sutures come out, no staples. So in the world when we were in COVID and you couldn't get patients back in and you couldn't get them to therapy or home therapists, it was also nice because there was no home maintenance or additional work. The patient just takes it off on their own at 3 weeks. So it really has been great. The downside is, just for those listeners, there is about a 2% allergic reaction. It tends to be in patients who have had adhesive allergies. And so when it does happen, it looks just like an infection. We've never had one turn into an infection, but it scares the hell out of you because it turns bright red. And so we treat it with some oral steroids and Benadryl. Just from an aside, for anybody who does try and use it, I always put that out there. In terms of work-life integration, this is probably the part of my life that I struggle with the most. I will be frank and honest. You're pulled in 100 different directions. Patients demand seeing because they can't get in for 6 months. Patients having complications after hours. You've got plans to go to your children's basketball game. Meetings, research, trying to be on the podium and do all of that. Jim Urbanek was a very close friend of my father worked under him, and he gave me some great advice early in career. He said, my first 10 years in practice, I said yes to everything. Absolutely. This project, this meeting. My last 25 years, I tried to find every excuse in the book to say no. So my point of that is that, burnout is real. I'm now 47 years old. I'm doing 1,200 cases a year. My back starts to hurt. I feel guilty. My kids are getting older, that I try to be finished every day by 5:30. I try not to plan things on the weekend. I try to forward look at important things in our lives, our families' lives, to make sure I'm there for those important things. But it is probably the thing that I look at every year most critically about how I want to change and be more effective at both my home life and my work life.
I can bring things to a close a little bit. I see you at the games, I see you at the practices, and I will say that this week I was admittedly removing a screw from somebody's patella while I was doing their tarsal tunnel release, and I thought about you because I couldn't remember with the name of the skin closure that you use, and I looked at the resin. I was like, "What's that thing that Nunley uses?" Because we had just talked about it when we were hanging out aside next to Dr. Aleem's grill when you and I were chatting. So, we all struggle with it. I think that you are clearly making an effort, and we were spending some good time together over the weekend. So. Kudos to you for everything you've done, and thank you for joining us on the Upper Hand.
Well, thanks for having me, guys. You're great partners, and I love the cross collaboration.
Yeah, thanks a million. Thanks for joining us for a brief period after rounds on a Saturday morning. So now go home, hopefully, and enjoy the fam.
I will. Thank you, guys.
All right. Thanks a million. I'm going to stop recording.